right. Hello, everyone, and welcome. My name is Deanna Fenton, Program Manager here at the Alliance, and I'm very excited to be welcoming you to today's donation-focused webinar, which will highlight unique donor management snags. Now, this webinar is sponsored by OmniLife, a mobile app developed for serving the donation and transplantation community. Working with all levels of transplant and OPO professionals, OmniLife provides one scalable, intuitive, HIPAA-compliant system, allowing you to communicate and collaborate with your internal team and external partners. To learn more, visit getomnilife.com or contact Liz Moore at the email address provided here on this slide. OmniLife is a proud 2021 advocate level corporate partner of the Alliance, and we thank them for their ongoing support. We are also so grateful to our sponsor as well as our presenters for joining us today. I know our presenters are very excited to talk about their experiences and share insights on how they've overcome some of these unique challenges. But before we go ahead and get started, I would like just to take a brief moment to share some important information and reminders regarding today's program. Now, for those of you who are joining us for the very first time today, we do ask that you take note of the Q&A feature that's located at the bottom of your screen in the Zoom navigation bar. All of your questions for our presenters should be submitted here. Now, for those of you who may have submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our presenters address them throughout the course of the presentation and our Q&A discussion. Now, should you have any additional questions that come up throughout the course of the presentation, please feel free to submit them in that Q&A box. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion where our presenters will address as many of your questions as time allows. Additionally, for those of you who may be joining us as a group, please take note of the following poll that I've just launched. If you're participating as a group, we ask that you complete this poll just to indicate how many people are approximately participating in your respective group. Your responses will help us and our two presenters gauge the level of participation and engagement in today's program. Now, for anyone interested in our upcoming webinars, please note that registration is currently open for our next transplant-focused webinar, which will highlight and talk about leveraging innovation and patient engagement in pediatric transplantation. You can join us for that on April 27th at 3 p.m. Eastern. Now, registration is also open for our next innovation-focused webinar, which will talk about strategies for establishing a successful hospital-based renal H&P program. That's coming your way on Tuesday, May 4th at 2 p.m. Eastern. Now, to stay up to date on all of our upcoming programs or for more information on either of the programs I just mentioned, please feel free to visit our website at organdonationalliance.org. Now, following the conclusion of today's program, we will be offering continuing education credits. For this webinar, there will be 1 CEP-C credit and 1 nursing contact hour available as a result of your participation. Additionally, as always, there will be a certificate of attendance available for those of you seeking CEs not being offered. Now, prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will give you an opportunity to provide us with your valuable feedback. If you happen to be listening in a group, please be sure to get the evaluation email from your group lead. Just as a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and begin today's program by introducing our moderator, Christy Birdwell, Hospital Services Liaison at Nevada Donor Network. Christy, it's such a pleasure to have you with us. And at this point, I'll go ahead and turn the floor over to you.
Awesome. Thank you, Deanna. I appreciate it. Good morning or afternoon, wherever you are in the US. We definitely appreciate you joining us for donor management snags, overcoming unique challenges in the donation process. I know that our presenters are very excited to get the information out there to you all. I am excited to just give a little background on our presenters. First, Liz. She is a graduate of the University of Toledo with a master's degree in organ donation and transplant sciences. With more than 9 years of organ procurement experience, she continues to seek ways to grow professionally and work to mentor those that are new to the field. Currently, she works for Gift of Life Michigan as a donation coordinator and is grateful for the lives she has the opportunity to impact every day. She continues to look forward to a long and fulfilling career in organ donation, in organ procurement, excuse me. Our next presenter I would like to introduce is Racheal Wulf. She's currently the manager of organ services at Nevada Donor Network. She started with the organization on the front lines as a procurement transplant coordinator in 2018 before she accepted a supervisor position and then moved into the manager of organ services. She received her Bachelor's of Arts in Zoology and her MSBS at the University of Toledo's Human Donation Science program. So we hope that you all enjoy what Liz and Racheal have for you. And I will go ahead and turn it over to Ms. Racheal.
Thank you, Christy, for that introduction. Good morning, everybody. Like Christy said, my name is Racheal Wulf, and I'm the manager of organ services at Nevada Donor Network. And I'm here to talk to you today about some of the unique challenges that we face in the donation process and how we are able to overcome those. So I will, we'll start out by talking about our DSA, identify some of the challenges we have within a smaller DSA, discuss how we address these obstacles, and then we'll go into more specific applications with a couple of case reviews. So I want to start out by giving a little bit of context for the DSA in which we operate. We cover most of Nevada except for the Reno area, which is covered by Donor Network West, and the Northeast corner, which is covered by Donor Connect, and have about 2.9 million residents. So although we cover quite a larger geographic area, most of Nevada is desert and people don't tend to live in the desert. So we have a little bit of a smaller population than you would guess from the geographic area. One of the pros and benefits of our DSA is we only have 15 donor producing hospitals. The farthest away is about 19 miles from our office. It really only takes about 45 minutes to drive from our northernmost hospital to our southernmost hospital. So not a lot of commuting, which is really nice for our frontline staff after they've had a super long shift or just a long day. However, we do have a couple challenges. First, we only have a single kidney transplant center. No other centers are currently transplanting any other organs within our state. So more than 95% of the organs procured within our DSA are transplanted out of state. And I imagine that with the new kidney allocation policy taking effect a couple weeks ago, we'll see even more kidneys starting to go out of state as opposed to staying with our local center like we would like to. Another challenge is our lack of procuring surgeons. Like I said earlier, we only have one kidney center. So we don't have any other abdominal surgeons. We don't have any thoracic surgeons. And up until a little bit less than a year ago, we did not have a single local transplant surgeon who is willing to participate in procurement in any way, not even those kidney only DCDs. So as you can imagine, this presented some significant roadblocks to quickly setting ORs. Interestingly, the challenges that other OPOs are now facing because of the transition to the nautical mile concentric circle method of allocating are challenges that we've started addressing years ago, just because the very nature of our DSA. It's a little bit hard to see on this map, but all of the centers in LA fall within this 250 nautical miles from all of our donor hospitals, while these centers in Phoenix and San Diego barely make the cut when we have donors at our southernmost and westernmost donor hospitals. The good news is, despite these challenges presented by our DSA, we are pretty good at making donation happen as often as possible. You can see here, we are second in the nation in organ donor per million population. And we are also leading the nation in the number of organ donors per 10,000 deaths, which means that we're really working to squeeze out every possible donor from our relatively small DSA. And it's not just about the donor numbers. We're also currently second in the nation in the number of organs transplanted per million population. And recognizing that every DSA is a little bit different, I just wanted to share some of the deliberate steps that we've taken to make this our reality. So we can really break down our success to three main focus areas. First, we've taken bold and deliberate steps towards establishing and nurturing relationships with transplant centers within our region and even national centers. This especially factors into our challenges with allocating livers that have been declined intraoperatively, since we don't have a local center that we can just drive down the road to with that liver and drop off so they can transplant to whoever they want. Second, over time, we've had a shift in our own organizational practices to mitigate some of the challenges of operating within our DSA. And then finally, we have a focus on building and maintaining strong relationships with our donor hospital partners within our DSA. So the first step of bridging some of the most obvious gaps within our DSA was contracting with a group of transplant surgeons out of Phoenix, Arizona to be our on-call procurement within our DSA. When other centers in our region accept a liver but ask for local recovery, we bring in the Arizona surgeons and pass along their transportation costs to the accepting center. The byproduct of this mutually beneficial relationship is having an aggressive liver transplant center on site and willing to act as an expedited backup in the event that the liver is declined intraoperatively. What this looks like in practice is us having a pre-identified backup center, which is allocated in sequence on the match run, just like allocating pre-OR, in addition to having an expedited backup center. So when a liver is declined intraoperatively, an offer is made in sequence to the predetermined backup center on the match run. And if they decline as well, then out of concern for cold ischemic time and in an attempt to avoid transplantable livers from being discarded, the liver is then allocated to the expedited backup and taken back to Arizona with the procuring surgeon. Obviously, our practice has changed a bit with the new expedited liver wizard and donor net, but we still maintain that practice of having a predetermined expedited center in the event that too much cold ischemic time builds up while we're running that wizard and allocating off of that new match run. Interestingly, as this became a more common practice for us, more centers in our region began expressing interest in being identified as that expedited backup center. So our administrators began visiting other liver transplant centers in Region 5 and having open dialogue about this practice of ours and discussing the possibility of identifying other centers who wanted to participate. Not surprisingly, some of these centers realized that they weren't actually aggressive enough to act as that expedited backup center for these marginal livers. But the continued conversations at the administrative level with a focus on transparency of our practices and customer service have undoubtedly led to smoother relations across the board, from the higher leadership level, the AOC conversations, and even on the frontline staff. So while we were making all of these changes with our external partners, we were also making changes internally to support these efforts. One of the simplest changes was standardizing the way that we document in the OR so that there's a clear documentation trail for any late declined organ that shows all of the steps we took to allocate in sequence before allocating to an expedited backup center. And this is a really crucial step when you find yourself having to write a lot more allocation inquiry responses to UNOS. And because we don't have a local liver or thoracic center to accept organs from us, we also don't have local centers putting pressure on us to manage donors in any specific way. So when we are coming up with some of our kooky donor management ideas, we're not having pushback from our local centers about, why are you doing that? Why are you doing this? So this lack of transplant outlet within our DSA is almost a blessing in disguise and has provided us the opportunity to develop our own clinical management protocols based on national acceptance data and best practices. Additionally, there has been a deliberate shift at Nevada Donor Network to tolerate longer case times. Being a mass exporter significantly complicates the logistics of planning for procurements on top of the considerable time it takes for us as an aggressive OPO to turn around organs that would often be deemed not suitable for transplant by other OPOs. It's really not uncommon for us to spend 3 or 4, sometimes 5 days on lung recruitment by itself, just because we refuse to give up on some of these lungs. We also take a pretty hard line stance on rule outs. And by that, I mean, we consider rule out to be a dirty word. We really put our money where our mouth is when we say every organ, every time, and we truly do exhaust all of our options for getting every possible organ transplanted, which means exhausting lists every time they're run, and sometimes even allocating internationally if all of our national centers decline. Lastly, while building and maintaining relationships with our donor hospitals might seem like a no-brainer, it has really been a key component that's contributed to our donor and transplant volumes we've been able to produce. Because we don't have hundreds of donor hospitals and they're all within, 20-mile radius of each other, we're really able to focus on our overall general presence on every unit in every hospital. We're able to focus our educations and our rounding practices to really emphasize the importance of following best practices and remaining compliant with referrals and sending in those updates that really help us set donation up for success, and highlighting the importance of donation and the hospital's role in donation. And because we have such a small team, OR team, we're only capable of staffing one OR at a time. So we're never having simultaneous ORs. So we really rely on our donor hospitals to collaborate with us to find creative solutions to some of the logistical problems we have during donor mania, when we've got a crashing donor over here, time constraints over here. So they're often bumping other surgeries to allow us to procure during some highly coveted time slots. And all of our efforts with our donor hospitals is really evident when you look at the top 20 donor producing hospitals in the nation for 2020, where 2 out of our 15 donor hospitals make the list. You've got Sunrise over here, number 11, and University Medical Center of Southern Nevada at 14. So some of the outcomes that we've seen because of all of these practices that we implemented. First, transplant centers are more willing to come to Las Vegas for organs. Even during COVID, when centers weren't really traveling outside of their DSA as much as they would have liked or would have pre-COVID, we've still had quite a few centers come out, take a look at that marginal liver, taking a look at some of these marginal lungs or even hearts. And the more they come out, the more likely they are to take it. We've also had an increase in liver utilization. So this graph, it's a little bit older, but it still shows the general trend that I'm trying to communicate. So we started this partnership with the Arizona group in 2018. And this gray line represents the percent of livers not transplanted after they've been intraoperatively declined. And as you can see that since we started contracting with this Arizona group, the number of livers not transplanted after an intraop decline has decreased by about 3% just in that 2.5-3 years, which is pretty fantastic. And then lastly, we are seeing success as a top performer in the new CMS final rule metrics. So you can see with the donation right here, we are solidly tier 1. We're number 4 in the nation. So even with the international metrics and the new final rule metrics coming up in the next year or so, we're still quite successful in making donation happen. So now that I have covered a little bit more of the high level practices, now we can go into some of the more hands-on examples of how we put this in practice and what makes it so successful. So the very first case that I'll talk about is our first expedited DCD donor. So we had a 65-year-old male who's admitted status post cardiac arrest, family elected to withdraw care, and authorized for DCD donation with a 6-hour time constraint. The important thing to remember is that prior to this, our fastest case was 24 hours. So to go from 24 down to 6 hours in a day or a year that we had been working on implementing this expedited DCD process was pretty daunting. But we are very lucky that this took place in a hospital where we had really great relationships. The OR was very accommodating. The pronouncing physician was very accommodating and very pro-donation. The charge nurse, the bedside nurse, even nurses on the floor not having to do anything with patient care, where it was all hands on deck, really trying to make sure that we had everything we needed to make donation happen for this family. We also had to make a couple of OPO adjustments on the fly. So first was the number of on-site staff. Normally we only have one PTC who does all the charting and blood draws and huddles and allocating and getting a surgeon in and all of that. But in this instance, we had 3 PTCs on site to really try to expedite everything, get the charting done, book a surgeon, book the OR. And we also had a family service coordinator who was very involved on site. She was helping us finding pronouncing physicians and communicating with the hospital. And then of course, supporting the family throughout the process. We also had to figure out how to expedite getting permissions from the medical examiner. Since we had never done this before, we're very fortunate. We have a position called a coroner liaison where their job is to create really great relationships with our medical examiner. We were able to expedite that permission process. And lastly, we had to get a surgeon. Our usual group that we bring in isn't used to us having ORs within 6 hours. So they weren't available. They're used to having at least a day to figure out, their own logistics and rearranging everything and figuring out who's going to come out here. But luckily, because we have such great relationships with regional centers, we reached out to a few abdominal surgeons within Region 5, and quite a few of them were willing to come so last minute. So one of them came in and recovered for us. So all in all, our total time for this case from authorization to OR time was 6 hours and 32 minutes, which is pretty fantastic after having only done this in 24 hours before. And both kidneys were accepted and transplanted. So all in all, very successful first expedited DCD. Since then, our shortest expedited DCD has been 4 hours and 18 minutes. So being able to shave off 20 hours from our previously fastest case time to 4 hours is pretty unbelievable and really speaks to our team here and their dedication to donation. And we've expanded this to all of our donor hospitals, so not just at the hospitals where we have super duper donation champions. We've developed a workflow that has predetermined tasks for PTCs on site, who's charting, who's doing the blood draw, who's huddling, who's finding pronouncing physicians, establishing all of those logistical tasks. Our hospital services team has done a really great job continuing our education about the DCD process in general, and also this new expedited process that we've got, what we need from them, what we can do to help them with this new process. And as this has become a more and more common practice, this whole process in general is becoming more established for both on the OPO side and for the hospital side. And soon to come, we are working on establishing a kidney pump program. So we'll be able to put some kidneys on a pump, work up some of the more marginal kidneys, and then continue with allocating. So we're looking forward to that. Now I'll go into a little bit more of some of the kooky donor management that we go into, specifically lung recruitment in this case. This was a 33-year-old male who was admitted status post cardiac arrest secondary to overdose, declared brain dead. At the start of the case, his challenge gas, FiO2 100%, PEPA5 was 174. So not the best, but not that bad either. And throughout the whole case, he had continual atelectasis in imaging of the left lower lobe, and we just couldn't get it popped open. So we spent 4 days on lung recruitment alone for this guy. And we also had a lot of involvement from our medical director. He's already very involved in all of our cases, but he was especially hands-on in this case. So we did quite a few weird things. We proned 3 times. We did some single lung ventilation. We did very aggressive CPT, Q1, Q2 hours while we were prone and supine. We did our Peatee maneuvers. I know everybody has their own version of Peatee maneuvers, but so we did ours. And then we had to do some very aggressive diuresing, and we ended up taking about 11 liters off of this kid and out of his lungs. So right off the bat at case start, we went prone. We did our Peatee maneuvers, CPT, diuresing, nothing super fancy besides being prone. After about 20 hours of being prone, we went supine to give the heart a little bit of a break. We did some cardiac management, did more of our Peatee maneuvers, did more CPT, more diuresing. And then we also changed the vent settings a little bit. So we alternated between a 1-to-1 inspiration to expiration ratio and an inverse ratio. So sometimes we'd go 2 or 3, sometimes 4 to 1, depending on how the donor was able to tolerate that. And we will alternate between those vent settings every couple of hours to really try to pop open those lungs. After about 6 hours of being supine, we went prone again, more Peatee maneuvers, more diuresing, more CPT. You can't tell, we've got a pattern, a lot of those things that we do. And continued with that alternating 1-to-1 and inverse IDE ratios. After 15 hours, we went back to supine, more cardiac management, more Peatee maneuvers, more 1-to-1 to IDE, inverse settings, more CPT, more diuresing. And then we proned for the 3rd time. This is when we did our single lung ventilation. This is when our medical director was incredibly hands-on. He's an anesthesiologist, so he's very familiar and comfortable with intubating and messing around with ET tubes. But it was really helpful for our frontline staff for him to come on site and walk us through his thought process and the process in general. And he felt that this was indicated due to the continued infiltrates and atelectasis showing in that left lower lobe in imaging. So basically he came on site, he pulled the ET tube back, placed it in the left lower lobe, a little bit in the left lung. And then our vent settings, they remain the same. We made sure our cuff was super inflated, so to really kind of minimize de-recruitment in the right lung. We kept our 1-to-1 vent settings, no Peatee maneuvers, but we had an FiO2 at 100%. And then after 2 hours, our medical director came back and returned the ET tube back to a normal position. And then we kept on with our Peatee maneuvers and CPT and diuresing. So all in all, after all of that, our peak challenge gas was 515. And the imaging after that last round of proning and single lung ventilation, that atelectasis disappeared, no more infiltrates, and it worked. So we went from a challenge gas of 174 to 515, I think over a long period of time, but I think it really speaks to our frontline staff who were determined to make this work, the donor family who understood the need for donation, our hospital was great, and our medical director being so hands-on. The outcome for this was that our lungs were accepted and transplanted, and last I heard the recipient was doing great. So all in all, another great success story. So that is all I have for you. Thank you everybody for listening. And now I will turn it on over to Liz.
Hi, thank you, Rachel, for the introduction. Good afternoon, everybody, and thank you for coming out today to listen to what we have to say. I am Liz Peatee, and I'm going to share our experience here at Gift of Life, Michigan. My objectives today, I will review Gift of Life Michigan's area. We'll discuss the logistical challenges of having an OPO that covers a large area, also the benefits and challenges of having a high volume OPO, the benefits and challenges of having transplant centers in your area, and I'll wrap up with presenting 2 separate case studies. So here at Gift of Life, we are the state's federally designated organ and tissue program. We serve a population of nearly 10 million. We have 176 hospitals with 9 transplant programs in our area. We were incorporated in 1971. and we have a full service laboratory and an in-house surgical center. So let's dive into our core purpose. We honor life through donation, and our values include determined, compassionate, and professional. Now, talking about the specifics of our area, Gift of Life office, surgical center, and laboratory, our start here on the map, is located in Ann Arbor, Michigan. Travel time from our donor hospital, from our office to a donor hospital can range anywhere from 15 minutes to 8 hours. The majority of our donor producing hospitals are located in the Ann Arbor, Detroit area, followed by the Kalamazoo, Grand Rapids area, then the remainder of the state. Last year in 2020, we facilitated 374 organ donors and 1,550 tissue donors. In 2010, Gift of Life Michigan began transferring our brain dead organ donors to an outside surgical center. We rented bed space and organ recovery suites at that center. Once this system proved to be successful in addressing logistical challenges, improving our donation outcomes, and many added benefits, we then broke ground on our very own surgical center. Our Gift of Life Surgical Center opened in the summer of 2016. Our center has 3 bed space donor care unit and 4 recovery suites. Since starting this program in 2010 to date, we have transferred 639 brain dead organ donors to our center and countless more tissue donors. So now let's talk about meeting the demands of having a large area. Here at Gift of Life, in order to facilitate our donor volume and meet the demands of a growing clinical division, we have implemented several creative staffing solutions, one of which was implementing a family services department that started in 2015. To date, we have 9 full-time family services coordinators in that department, and they are charged with approaching a majority of our families. Currently, they're approaching on approximately 60% of our donor families. Additionally, in the end of 2019, we added a referral response coordinator position. We currently have 3 full-time employees in that position, and we are looking to hire 1 more. They are charged with completing initial on-site responses, face-to-face follow-ups on referrals that we are currently following, and they are all trained in approach. Given that we do cover a large area and having a surgical center, we have implemented several innovative practices. The first being an intraoperative management role. What that looks like is having organ donation coordinators that are specially trained in managing the head of the bed or the typical anesthesia role. This job proved to be very successful, not only in alleviating the stress of having to partner with an outside anesthesia group, but also building upon our clinical department's skill set. In 2018, we implemented a DCD lung reintubation program. So the program began with staff who had previous experience in intubation. Since starting this program in 2018, we have been able to participate in 46 potential lung reintubations, with 24 of those expiring and requiring reintubation. Not only does it build on our coordinator's skill set and provide an opportunity for growth, there is also a large cost savings. So to date, we have saved a little over $43,000, and it is a cost savings per case of $960. Additionally, having the skill set in-house, we have had 4 separate opportunities at our surgical center where patients were in need of either a tube exchange or reintubation, and our staff was able to do that in-house. This whole program was started because we had 2 donor hospitals that refused to provide us support in this area. So instead of losing all these potential opportunities, we decided to keep that in-house and train our staff. Additionally, to meet the needs of our own center, we have trained our coordinators in arterial line placement and bedside bronchoscopy. To meet the demands of our large donor volume, Gift of Life has also recruited our own full-time abdominal recovery surgeon. Here at Gift of Life, it is not uncommon to have multiple recoveries happening simultaneously or several within a 24-hour time frame. So having our own full-time abdominal surgeon reduces that burden on our local recovery surgeons and also provides us an additional layer of support. At our surgical center, our abdominal surgeon is able to come in and complete bedside liver biopsies if needed and central line placement. Well, bigger isn't always better, as many organizations struggle with staffing. Gift of Life, we are not immune to these issues. So here at Gift of Life, we have 38 full-time coordinators. We have 3 additional that are in orientation, and we are fully staffed at 43 organ donation coordinators. We have 18 coordinators who have been with Gift of Life for 2 years or less, and our average years of service is roughly 3 years. On a day-to-day basis, we have 14 to 16 coordinators on call to facilitate up to 6 brain dead organ donors. As we all know, DCD donors chew up a lot more staff, especially since we've established our own DCD reintubation program. We always have multiple coordinators on site to facilitate this process. That being said, in times of high donor volume, our management does a good job at closely monitoring our donor activity and our staffing, and we'll reach out to coordinators and offer incentive pay for staff to pick up. And fortunately, we do not have a case in history that we've had to turn away from due to staffing issues. As you can imagine, covering a large area, it is difficult to get on site in a consistent and timely fashion. So we, in the end of 2019, began closely monitoring the amount of time it takes to get on site for initial responses. It is our goal to arrive on site in 2 hours or less, and it's something that we are striving to achieve. We know that it's something that we're not routinely doing currently, and we're going to adjust our staffing needs accordingly. And again, as many of us have encountered, having a large, diverse area can bring challenges of its own. So not only amongst our donor family populations, but also our hospital dynamics. So implementing something that might work very well in the Detroit or Ann Arbor area may not work so well on the other side of the state, the Kalamazoo or Grand Rapids area. So continually identifying the specific needs of our donor families and our hospital partners to make sure each donation opportunity is a success. Now let's talk about our transplant program partners. So here at Gift of Life, we have 9 transplant program partners. Those that are highlighted in green are in the Southeast or Detroit, Ann Arbor area. And those that are highlighted in blue are in the Southwest or the Grand Rapids area. There are countless benefits of having transplant programs within your area. I've highlighted a few that we will discuss in further detail. So as I mentioned earlier, it is not uncommon at Gift of Life to have multiple organ recoveries happening simultaneously or within a 24-hour period. That being said, having so many transplant program partners in our area, we have a significant pool of resources to pull from to facilitate that large donor volume. That being said, it is very uncommon that we're having to delay or push back OR cases because of a lack of staffing. Additionally, having an organ donor on site at a transplant hospital provides an added layer of support in overcoming roadblocks. Imagine that you have an organ donor, you're on site at a transplant hospital, and you're having issues with getting a procedure completed or scheduling an OR. We have our transplant partners that we're able to reach out to, and majority of the time they're able to facilitate whatever it is that we are requesting to keep the donation process moving forward. Also, having your own surgical center does require added support. Our transplant program partners are kind enough to provide us with a pool of intensivists and surgeons that have made themselves available on a 24/7 hour basis for special needs, such as procedures if needed, central line placement, chest tube placement when needed, just to help make the surgical center a successful process. Now, rapid recoveries. So having an organ donor at a transplant hospital does alleviate some stress factors. So imagine you're at a transplant hospital and you have a donor that becomes unstable, or you have families saying that they want this case to be done immediately. We are then able to get the process moving as quickly as possible. There's generally an ASIN certified surgeon not too far away. The ORs are used to these types of cases so that they can mobilize very quickly. And these are cases, albeit very rare, that we're able to get into the OR within a few hours versus losing the opportunity altogether. Additionally, here at Gift of Life, we do have a weekly case review where we discuss the cases from the previous week. We do invite our transplant program partners to participate in these opportunities, and they can provide us real-time feedback and updates on how a recipient is doing. Also, they can provide feedback on how we can grow as an organization, which helps Gift of Life Michigan stay on the forefront of organ donation and transplant. We have seen an uptick in the request of local recovery surgeons with the liver allocation system, and also during the time of COVID. So we do have the opportunity for a local recovery surgeon, not only for abdominal organs, but additionally for thoracic organs. And we did see the request in 2020 more with thoracic organs than we ever had in the past. So this is something that we're able to offer to our outside centers and make sure we're fulfilling the needs for those potential recipients. And last, but certainly not least, intraoperative organ declines, specifically the liver declines. Reviewing data from 2020, we found that there were 12 separate cases where we had placed the liver with an outside center. The outside center requested for local backup, or local recovery rather, and they ended up declining the liver in the OR upon visualization. We were then able to pause and reallocate the liver to a local center prior to moving forward with cross clamp. In addition to those 12 cases, there are 2 additional cases where one of which is a DCD case where the liver was declined after cross clamp due to 20-minute warm ischemic time. We were then able to get that liver transplanted locally. And then lastly, there was an additional case that we had exhausted the liver match run with no interest in transplant. We had local recovery for the kidneys. Upon visualization of the liver, deemed that the liver is transplantable, we were able to allocate that organ and get it transplanted. So these are 14 opportunities that may have otherwise been lost, that given our partnership with our local centers, we were able to get these livers transplanted. And looking at our organ dispositions, a little bit different from our partners in Nevada. We keep 56% of our organs locally, and that was from 2020. And so far this year, 2021, we're seeing similar trends of about 59% of our organs staying locally. There are unique challenges to managing organ donors at transplant hospitals. We have all been in the situation where we have hospital staff that has bias in facilitating the donation process. However, being at a transplant hospital comes with some unique bias. So you might have a nurse who had taken care of a recipient in the past, and that has soured their experience. And they bring those feelings into the donation process. So overcoming and building upon those relationships to make the process run smoother and hopefully to change the opinions moving forward of the staff. Also, sometimes there are blurred boundaries related to management of the donor. So you're at a transplant hospital, you've allocated organs, you may have placed an organ with the hospital that you are in. The team then takes it upon themselves to go into the donor's hospital chart, and maybe they place an order or they cancel an order that the OPO has placed, all without our knowledge. So just reminding our transplant center that this is a partnership, and if they do have a request, they need to follow the appropriate channels to get these requests fulfilled. Also, having organ donors at transplant centers creates an added challenge in maintaining donor confidentiality. So if you can imagine having an organ donor on the same unit as a potential transplant recipient of either your donor or a non-related donor, if that recipient's family is on site and they notice that special attention is being paid to a particular room, that family may then connect dots that are or are not there. So it's important for the OPO staff to remember to maintain the donor confidentiality and remind the transplant hospital staff as the same. Additionally, as honor walks have become more and more important, this also is an opportunity for a breach in donor confidentiality. So again, addressing these situations as they arise and keeping it in the back of your mind that this could be a challenge. And then lastly, as I identified in an earlier slide, our Gift of Life Recovery Center is located in Ann Arbor, Michigan. So if we have a brain dead organ donor that might be closer to a Grand Rapids Transplant Center, there may be some conversations about keeping the organ donor closer to their center to make the transportation logistics much easier. How Gift of Life has handled this in the past is to maintain consistency in that we are going to transport our donors down to our center. That's where the recovery will occur, and knowing that it has not impeded transplant in the past and should not in the future. All right, so let's dive into, I have two separate case studies I'll discuss. So our first is a 39-year-old female. She is a registered donor. She is admitted status post motor vehicle accident. She has several injuries, which include pelvic fracture, sacral fracture, multiple lumbar spine fracture, left-sided rib fractures, and a small liver laceration. Her labs at declaration, hemoglobin is 6.9, potassium is 2.8, and O2 is 61 on 100%. Additionally, she's on 90 mics a minute of Levophed, vasopressin 2.4 units per hour. We started this case up on a Friday night. We were at an outside hospital and they were not being supportive of the donation process. They were not wanting to comply with transfusing blood products. There was no staff that was on board with chest tube placement. So despite the risk of moving to our center, the decision was made for immediate transfer to our Gift of Life Center. Total travel time from the donor hospital to our center in this situation is 3 hours. Fortunately, the donor made it through transport okay. The only significant event, she was sitting in the 80s, but had been, even at the donor hospital. Once the donor arrived to Gift of Life, we contacted one of our transplant program partners that provided us with a thoracic surgeon to come in and emergently place bilateral chest tubes. We were then able to start transfusing blood products. That same surgeon also completed bedside bronchoscopy for us. And once we stabilized the donor, we completed an echo the following day. I chose this case study because it does highlight the partnership between Gift of Life and our transplant center. Additionally, it highlights the importance of having a surgical center as an alternate treatment facility when we have hospitals that are not being supportive. And it highlights the skill set and competency of our frontline staff. So in this case, we had a great outcome. 4 lives were saved with heart, liver, and bilateral kidney donation. My second case study, I have a 37-year-old male. He has Down syndrome and he lives full-time in a group home. This patient was found unresponsive. He has a legal guardian that works in conjunction with next of kin in decision-making. The patient was declared brain dead on October 28th, and the guardian then had to seek approval from the court for removal of support. At that time, Gift of Life evaluated the case, and this patient was ruled out for organ donation due to multi-system organ failure. So at time of evaluation, his creatinine was 4 and he was making no urine. His AST was unreadable at greater than 1600. ALT was 3,386 and O2 was 70, and these were all still trending up. We did continue to follow the case, and the court hearing was set on November 2nd and then delayed to November 3rd. We then reevaluated the case on November 2nd, and fortunately there was some improvement in organ function, and we approached next of kin for donation. Labs at the time of approach, creatinine had went up to 5.6, but he was now making a decent amount of urine. AST came down to 574, ALT 882, and we're oxygenating that much better with a PO2 of 101. Family was supportive of donation at that time, pending the court's decision. So on November 3rd, the court did sign off on this case. However, the donor hospital would not allow Gift of Life to become involved in care until physically receiving the documents from the court saying that we could do so. Unfortunately, those documents did not come until the evening of November 4th. At that time, we very quickly mobilized and moved the patient down to our center to proceed with aggressive management of this case. And on November 8th, we took this donor to the OR. Our terminal labs, his creatinine was 3.6, AST is 46, ALT of 97, and our peak challenge gas was 509. I chose to highlight this case because of the unique dynamics. And I think this was COVID-related delays. Also, having to seek out court's approval for removal of support in a patient that is declared brain dead. I think that's definitely a situation where, unfortunately, there's a lack of understanding in the community about what brain death is. And then in many cases, this is an opportunity that we may have otherwise lost, but sort of a blessing in disguise that this case drug out over these number of days, and we were able to get these organs turned around and have a great outcome. So 4 lives were saved in this case with bilateral lung, liver, and kidney donation. So I just want to give a big thank you to the Alliance for having me participate today, and our partners in Nevada, as well as here at Gift of Life. So I will now turn it over to the Q&A session.
Thank you so much, Liz, and thank you, Racheal. Both such fantastic presentations. I really appreciate you both sharing some of your experiences. We're now going to go ahead and open the floor up for questions. So for those of you who have any questions, please go ahead and submit them in the Q&A box. Just as a reminder, that box is going to be located at the bottom of your screen in the Zoom navigation bar. So again, go ahead and submit your questions. And at this point, I'll go ahead and turn it over to Christy to facilitate our discussion. Thank you.
Thank you. So it looks like we just right now have a comment where we said just great work to you and your team, Racheal. So thank you so much for that. Looking at questions that were previously sent in. We've spoken about medications and just different things like that. So one of the questions on here was what the use of albumin in Lasix for third spacing, and also benefits of using T4 versus fluid resuscitation. I don't know who wants to kind of discuss their experience with that.
Yeah, I can start with that question. We find that a lot of our donors are very fluid overloaded, but they are all third spacing, so they're intravascularly dry, but still are 10, 13, 15 liters positive. So albumin in Lasix is one of our best friends. We use it a lot when it comes to fluid resuscitation rather than giving crystalloids if they aren't truly hypovolemic. So we use that for pretty much every single one of our donors. Sometimes we have to use very high doses of Lasix, and sometimes we also use Bumex and Diaryl, a combination of all three, to kind of kickstart urine output if they're not producing any urine. But I know some OPOs have some feelings about colloids and their donor management, but we're a big fan of them.
All right. Liz, did you want to add anything?
Yeah, to speak to the second part of the question in regards to using fluids versus T4, Gift of Life, we have stopped using T4 in 2019, and that was based on data out of St. Louis, where they had, I believe it was a multi-OPO study in regards to fluid versus using T4, and there was no increase in organ utilization with the use of T4. It is something that right now we are still tracking to see what our stance is on, but yeah, we are not using T4. And I know during organ allocation, we're still getting the question, is this patient on T4? And we say no, and the transplant centers remain to be shocked. So I think that it's common practice still to be using T4, but great question, thank you.
So another question that was on here, and since was regarding patients' BMI. How do each organ procurement organizations take that into account?
For us, it really only matters for potential DCD donors. But even then, it has to be an insanely high BMI. I think the one time that I saw BMI used as a rule-out criteria for DCD, it was almost 70. We've had DCD donors of BMIs with 50, 55, almost 60 before. So we very rarely use BMI as a rule-out criteria.
Yep, same here in Michigan. It's definitely something that we are aware of, but is not a rule-out criteria for us.
Another question, I still don't see any questions that have come in. However, another question that we did receive prior, let's see, what has been your experience so far with released organ match runs? Do you have any advice?
We haven't really had any issues with them yet. We haven't really had to use a released organ match run, so I can't really give any advice other than, just given the nature of our DSA, we're pretty used to allocating to everybody within our region. So I don't really anticipate a whole lot of change in our practice when it comes to kidney allocation for those released match runs.
Yeah, I second Racheal's stance. It's not something that we've had issues with, and I don't foresee that being a challenge in the future.
Okay. I guess I will ask one more out of this questions that we received. I guess we can kind of discuss the maintaining the dry donor. Just kind of what your ideas are on that and normalizing sodium levels and the battle between keeping a level under 155 while appeasing heart and lung teams' desire for the donor.
Vasopressin is our best friend when it comes to our super aggressive diuresing. We'll just give super mini baby doses, like 0.007 units. And so it doesn't really inhibit our urine output, but it still helps us maintain that lower sodium level. We'll also do free water flushes down the OG or NG tube if we see our sodium creeping up a little bit. We're also careful of how fast we're diuresing. So that way we're not all of a sudden at 155 and then our sodium is 180 12 hours later because we've pulled off 6 liters in 12 hours. And in the occasional super high sodiums, when we do accidentally let it get out of control, is enemas, and it works like a charm. Hospitals aren't really a big fan of that, but they understand. And actually a few units have used that for their own practices when they are trying to bring sodium down for brain death testing. So it has been helpful.
Yeah, I second everything Racheal said. Fluid management could be a whole webinar in and of itself, but definitely vasopressin is your friend, free water flushes as well. But there are a couple of questions in the Q&A bank. Do you see that, Christy?
I do, yeah.
Cool.
So we did receive a question from John. With cases that can stretch to 4 or 5 days to improve like lung quality, what is your practice in updating families on progress by family services? So in other words, do you typically update on management allocation daily, twice daily, or only upon request?
That's a great question, John. We have a really great family service team who maintain that relationship throughout the case with the donor family. So it really depends on the donor family. I know we offer them to have those daily updates when we're having our authorization conversation and we're talking about what that process is going to look like. Some families only want an OR time and they don't really care about everything in between. They just want to know when they can come back to see their loved one. So it's really on a case-by-case basis with family, and really reiterating the importance of donation, and right from the very beginning setting that expectation that it could take days and not hours like we're used to. So by setting that early expectation, we find that we haven't really had a whole lot of issues with families getting antsy and wanting the process to be done. But in terms of updating, it really depends on the family of how often they want it or if they want them at all.
Thank you, Racheal. Liz, it looks like we have a question that came in for Gift of Life Michigan.
Yeah.
For locally procured kidney, how often do organs get refused after being received by centers for issues such as inaccurate measurements of the vessels and extra vessels that were not reported?
So I can't imagine it happens too often. I think if it was happening more often, that we would be hearing about it more on our case reviews, but it's something that I personally don't have data for. I do have my contact information in the presentation, so if you want to contact me outside of this forum, and I can dig into that and provide more detailed information for you.
Sounds great. So far, it looks like that's all the questions that we have received.
All right, perfect. Well, that said, I think we can go ahead and conclude today's webinar. But before I go ahead and close this out, I just want to once again thank our presenters, Racheal and Liz, as well as our moderator, Christy, for doing such a phenomenal job at coordinating today's presentation. I know there were a few questions that we received beforehand that we could probably talk about at length, but unfortunately we are limited on time. So I appreciate your efforts in addressing as much as time would allow. So to our participants, if you do have any additional questions pertaining to the specifics of donor management and all the various components and processes of that, please use the post-webinar evaluations as an opportunity to not only share your feedback, but also share any recommendations or thoughts that you may have on other areas of donor management that you'd like to see us cover in the future. So with that, we look forward to reviewing your feedback, and we thank you for your participation today, and we look forward to seeing you at a future webinar. Thank you all so much. Take care.